Thank you so much for having me here. I'm very pleased to be here to be able to share my experience with you in implementing the Grady Interpregnancy Care Program, which we've specifically implemented as a strategy for engaging women in their own primary health care following the birth of a very low birth weight baby at Grady Memorial Hospital. So the Grady Memorial Hospital is our indigent care hospital in downtown Atlanta, and I'll tell you some more about that. Really, at the time we did this, back in 2004, 2005, our rationale for doing so was that at that time there was a growing body of evidence that linked an adverse birth outcome, particularly a very low birth weight baby, to underlying aspects of the woman's health. It typically wasn't something going wrong in the pregnancy. These were women who had unrecognized and poorly controlled medical problems, frequent and periodic reproductive tract infections, including BV as well as STIs. Some had substance abuse disorders, periodontal disease was common, and psychosocial issues such as stress, anxiety, depression, and many of them were also facing domestic violence. Evidence at the time was also very much in support that short pregnancy intervals, specifically having babies less than 18 months apart, were increased the risk of preterm and very low birth weight as well. And at the time, when we were devising this intervention, we knew that there was no prenatal assessment or intervention that was identifying that woman who would have her first preterm or very low birth weight delivery. But what we did know was that once a woman had one of these adverse outcomes, preterm or very low birth weight delivery, she was at very high risk for having that same outcome again and again and again, particularly if her health conditions that may have contributed to that first birth were not addressed, and she was not able to better space her pregnancies and get some healthy spacing between them. So the goal of our project was really, as a pilot project, to evaluate the effectiveness of delivering this package of interpregnancy care, which I'll tell you about, toward improving the woman's subsequent reproductive outcomes, and also with the goal of improving the woman's own underlying health status by delivering this primary care and helping her in setting and achieving some reproductive goals. And we hoped with our intervention and counseling of her that her goal would become to wait at least 18 months before conceiving another child. So let's step back and look at our definition of interpregnancy care. Carla gave a definition, or you all supplied a definition that was very much on target. The one I really like was articulated by the LA Best Babies program. They say it's medical and psychosocial care provided from the birth of one child through a subsequent pregnancy to improve the woman's health and address modifiable risk to the pregnancy and to the woman's underlying health status. And I like that it really emphasizes women's health. Milton Kotelchak also has a kind of a brief definition. He says a subset of preconception care that addresses the continuity of risk from one pregnancy to the next. So it's really just preconception care that's recognizing that whatever that first outcome is very likely to influence the next. And again, I've given you some of our rationale for putting our package together. Additional rationale for doing interpregnancy care is these are women who are known to the healthcare system. Most of them have had prenatal care and delivered in a hospital. All the births are identified by state-filed certificates. And even if women don't complete a pregnancy, if they have miscarriages or abortions, they're still receiving care somewhere. So that's a point where you can intervene with a woman, talk to her about reproductive planning, reproductive counseling, and addressing her own health care needs. And when we're talking about interpregnancy care for women with a prior adverse outcome, these are definitely women with demonstrated reproductive potential. We know they can carry a pregnancy, and we know if they've had this one adverse outcome, they're at such high risk in a subsequent outcome. And that risk of repeatability is much greater for African American women than it is for Caucasian women. And if you take teenagers, the risk for a teenager repeating an outcome is double what the risk would be, the already elevated risk is for a woman who is not a teen. And all of this, again, just underscoring that this is an underlying women's health issue, not really an obstetrical issue. So if we look at the evidence that informed our package for why we put together the package we did, there were really three big areas. We looked at the evidence for birth planning and spacing, evidence for specific interconception strategies, and then any evidence for packages of putting interventions together more in a primary care approach. Because as they mentioned, at heart, I'm a family physician, and I was looking for more evidence around a healthcare package, not addressing one particular area of a woman's health. And I'm sure most of you know this, but it just really bears repeating that there is good evidence, and this is something we have to convey to our patients, for birth planning and spacing. Women who have unintended pregnancies have an increased risk for detrimental prenatal behaviors, presenting late for prenatal care, not partaking in their care, and have an increased risk of both preterm and low birth weight deliveries, as well as negative health and social outcomes for the mother and child. And we know through good systematic reviews that these short interpregnancy intervals definitely increase a woman's risk for preterm birth, low birth weight, and small for gestational age. So these are just things that use in counseling for women so they can understand there's real good health reasons for spacing their pregnancies. Also, there were no real packages put together at the time that we were putting our package together. All we had were some very targeted interpregnancy care studies that had looked at one particular adverse outcome, knowing that folic acid helped those who'd had a previous neural tube defect, those with binge alcohol use disorder. There was shown that brief interventional counseling for those women could decrease their chance that their subsequent pregnancy would be exposed to alcohol. And then around diabetes, probably the most evidence was around diabetes. If a woman who had adverse birth outcome related diabetes, that intensive work with her on her diabetes prior to her next pregnancy did improve her compliance with her care and subsequent birth outcomes. There were also gaps in the evidence in important areas, but very observational data that certainly in my opinion, supported that underlying bacterial vaginosis, periodontal disease, and psychosocial stress were likely contributing to adverse birth outcomes, particularly for African American women who were disproportionately suffering from bacterial vaginosis and recurrent BV. So even though at the time we designed our strategy, there wasn't hard evidence for these, we included addressing them in our package based on what we thought was good evidence at the time. And this is just to say that when we looked at IPC packages, we had some folks whose work we wanted to build on, and oops, sorry, I advanced a little too quickly. The most notable one was the work out of Denver, the Denver case management home delivery model, where they had resource mothers going into the homes of women who'd had low birth weight babies, and they were mostly delivering social support, behavioral intervention, and helping women get to their next appointments. And we really based our work on a lot of that publications coming out from that Denver model at the time. Since then, there's been other work coming out. Healthy Start has been evaluated, and in terms of outreaching to women with social and biobehavioral risks. And there's certainly evidence, some limited evidence, that Healthy Start was effective in helping women address their health behaviors. And also since then, Drexel University and the CPAWS have performed studies. And I don't have time to go into the details, but I just wanted to certainly make it clear that we are not the only package for inter-pregnancy care, and you can go, and each targeted sort of slightly different population. I think our population is maybe more similar to who you may be targeting, but there's others you can read about if you would like to learn more. So who were our participants? For our program, we were targeting African American women because we were in Grady Hospital, and we knew in Georgia and certainly in Atlanta the racial disparities were so wide for birth outcomes. That was our rationale. And we were targeting those who qualified for indigent care through Grady Hospital. These were very low socioeconomic status women, and we had funding from Healthcare Georgia Foundation to provide this interpregnancy care and case management to all the women that we could enroll in a 3-month period. So it was very small and focused, and we could get all the women who met those eligibility criteria in a 3-month period. And really, what was our intervention? I would say as a family physician, I'm pretty proud that our intervention was really primary care. What it consisted of was definition of an individualized interpregnancy care plan that we made at the postpartum visit. We used intensive case management to get the women to the postpartum visit, and then we were the ones providing that postpartum visit, myself as a family physician and a nurse practitioner named Cynthia Dubin. So we did her postpartum visit, but really we used that visit to address 7 areas, to build a plan for that woman to address 7 areas linked to adverse birth outcomes. We addressed reproductive planning, and helped her articulate a goal for herself and choose a method of contraception. We addressed screening, prevention, and treatment for reproductive tract infections. We addressed micronutrient supplementation, management of any chronic diseases she had, treatment and referral for substance abuse, screening, treatment, referral for depression, anxiety, and other psychosocial stressors in her life. And we were able to get them to a dentist. Again, this was covered by our grant, that we were able to get them dental screening and care for any periodontal disease that they had. So this was, this sort of articulation of this care plan took place at the postpartum visit. And then we were able to provide primary care services and social support services to help the woman meet this plan for 24 months after the birth of her baby. And how we provided that care over the course of the 24 months was through care with a multidisciplinary team. We had, as I mentioned, family physician and nurse practitioner. We were sort of in the clinic helping managing these women, but the key people were also the nurse case managers calling the women between appointments, ensuring that they had appointments and transportation scheduled. We had a resource mother, as well as a social worker who was kind of supervising a resource mother at a high level, but not really interfacing with the women. And then throughout this 24 months, they had their primary care visits really every 1 to 3 months, depending on, some of the women were very sick and they were seeing us monthly, women with out of control diabetes and hypertension. But for most women, it was every 3 months. And we did this primary care in a group setting. We modeled it on the centering pregnancy model because our nurse midwife working with us was a delivered centering pregnancy care. And so she came up with the idea of delivering it in a group way following that same model. And she, myself, the resource mother, the nurse case manager, all attended the group meetings. And if anyone had individual health needs, we saw them after the group visit to address individual needs or any individual counseling and help them get to their referrals. Throughout this 24 months, I think a key portion as well was the outreach that was really being handled by the resource mother. She was in contact with our women at least monthly by telephone, tried to make home visits monthly. That was a little harder to achieve just with schedules, but she certainly tried. And she was really addressing the women's social needs at that time and linking her to resources in the community. So then we sought to really evaluate. We delivered this program. We enrolled women over 3 months. We were able to get 29 women in 3 months. Then we had to cap and follow them forward for 2 years. And to evaluate our program, we wanted to compare their health status before, pre and post enrollment in the program, but we also really wanted to compare the reproductive outcomes for the women we cared for in our program to a comparison group. We weren't randomizing our delivery, so we didn't have a randomized trial, but we had a historical control group. Basically, they were women who lived in the same area, had very similar birth outcomes, but delivered at Grady before we got started with our program. So just so you understand when I show some comparison, who this comparison group was. And the first thing, just from a feasibility standpoint, we wanted to find out, will women even participate? If we're offering them all of this primary care, this outreach, will they participate? And as I told you, we had 29 women who enrolled during those first 3 months, the 3 months that we could enroll them. And at the end of a year, we had 21 of 29 of them participating. And we really wanted to focus on why. Well, who were these 8 women that we lost and why? And 2 of them moved out of state. 3 were either disenrolled, an additional 3 were lost to follow-up. And what's important to note about those women are those were women with substance abuse disorders who we weren't effectively able to really help or engage in rehabilitation. And so that's just an important point as we'll talk about in terms of lessons learned. During the second 12 months, we were able to retain 16 of 29 through the full second year. So again, we lost some women to follow-up, and we lost 5 additional women to follow-up. One because she gained health insurance and had a private provider, so that was great, but 4 additional who were lost to follow-up who again had substance abuse issues that were not being met with the rehabilitation services we were trying to link them to. So substance abuse, active substance abuse was a huge barrier to maintaining engagement in the program. So if we just look at those 21 women in the first year who were coming every 3 months to their visits and participating in the resource mother outreach, we just wanted to look at what kinds of acute problems were we addressing among these women, what sort of health problems. I think it was really notable. These were the few I wanted to, that really 75% of them were experiencing sexually transmitted infections, and it was often repeated and recurrent sexually transmitted infections in that first year. So that is a common problem among women who you would be treating with delivering inter-pregnancy care to, particularly if they've had an adverse outcome. As was postpartum depression, 7 of the 29 had periodontal disease, and about a quarter of them had iron deficiency anemia. So these were just the common acute conditions. This is a very busy slide. We're not going to go into all the details, but the point of this is that 7 of our 29 women, so nearly a third, had pretty severe chronic disease. And they had diabetes, hypertension. We had women with sickle cell disease, valvular heart disease, hepatitis C. And the point was that these women, between pregnancies, they never had any source of care. So their condition went unaddressed until they became pregnant again, and then it was minimally addressed because you couldn't really address it very well during pregnancy. So the point is, by enrolling and we were able to engage them throughout the 24 months, we were able to achieve improvements in their chronic health conditions. Now, if we get at we also wanted to look at the impact of our program on reproductive planning. This was when all this concept of reproductive planning was very new. And what we wanted was not for us to tell women, you don't need to have a baby for 18 months, but to work with them to provide education about how important birth spacing was, and to have them articulate their own goals. So for those women actively participating, all of them did articulate a goal for themselves, a reproductive goal. Some of them, and at that time, none of them really wanted, many of them had babies in the NICU. They did not want to get pregnant again. And 21 of 21 did choose a method of contraception, and we'll look at some of the outcomes related to that. We wanted to look at conception within 9 months and within 18 months, with 18 months kind of being our ideal window. And as you can see, we didn't have any one of our women get pregnant within the 9 months. And this is in contrast to our comparison group of Grady women who delivered the year before and didn't get the intervention. Almost a third of them were pregnant within 9 months. Then if we look at 18 months out, so looking at some of the effectiveness of our program, we did have 5 of our full cohort of women become pregnant within 18 months. And these would be regarded as unintended pregnancies, in that these were all women who said, I didn't want, they were telling us all along they didn't want to be pregnant. But this is in contrast to fully 50% of our comparison group became pregnant. And if you look at this, they became pregnant more than once. If this is not just looking at the total number of pregnancies. We had women, 3 of which experienced 1 pregnancy within 18 months, 2 of which experienced 2 pregnancies. And so there were more, but in the comparison group, the situation was quite a bit worse with 7 of the women having 2 pregnancies within 18 months. But from the statistical analysis, which I don't want to go too much into, we'll just say that we were able to show that we had a 61% reduction in the average number of pregnancies conceived. And when we looked within that 18-month window, and when we looked at the adverse outcomes among those conceived pregnancies, again, I'm not showing you all the details here because I have limited time, but the bottom line was we had, over the course of 18 months, 2 of the women experiencing an adverse outcome, for a total of 3 adverse outcomes. And in the comparison group, there was 17 even experiencing 1, or 13 experiencing 1, 4 experiencing 2. So we, with statistical analysis, had a 72% reduction in adverse pregnancy outcomes. So that was one of our things we wanted to demonstrate, or we wanted to explore. Were we effective in helping women articulate a reproductive plan, to stick with it, and help them achieve a reduction in unintended pregnancy rates, as well as improvements in their health? We looked at the cost of this, and the cost doesn't appear really inexpensive if you just look at it alone. We, again, can't go into the details of the cost analysis, but when we broke down all of the work that we did with our full team, doctors, nurses, case managers, we said it was about, over the course of 24 months, just over $4,000 worth of care that was delivered. But 2 of our women, we only had 1 who had a live-born, very low birth weight baby. So we kind of tallied up the total care for these women, plus the cost of that 1 low birth weight baby. And then we contrasted that to the low birth weight babies born born in the comparison group, who there were 5 of those, and when we compared the net savings to the cost of those 5 low birth weight babies born in the comparison group to just our 1 in the intervention group, over 24 months we thought we were saving over $100,000 by delivering the care versus not delivering the care. So what did we learn about this program? And we're going to talk a lot more about the nuts and bolts of how to implement over the course of these learning sessions. But some big picture things we learned was that interpregnancy care, when done systematically with risk assessment, was important to identifying and managing acute and chronic conditions that we know are linked to a woman having another adverse outcome. It was effective in helping women develop a personal reproductive plan, and it did help all of our women achieve at least a 9-month interpregnancy interval, and it helped reduce the average number of pregnancies conceived within 18 months, and again, noting that those pregnancies were unintended, so we were preventing unintended pregnancies, not intended, and the average number, and we also were able to reduce the average number of adverse pregnancy outcomes. Regarding the content of care, we recognize that there really is a substantial prevalence of unrecognized or poorly managed chronic health conditions in these women, thus underscoring the importance of their primary care. And just when we look at acute conditions, reproductive tract infections, both BV and STIs were extremely prevalent in this group of women. And we learned we were not very effective with substance abusers, certainly with substance abusers who we were not effective at enrolling in a rehabilitation program were very difficult to track. And all of our really loss to follow-up was among that group of women. So I still don't feel like I have a strategy for telling you how to outreach to your substance abusers. That's a group who we definitely lost. But just as I believe it was Carla said, we also learned during the second year of our program, when we were able to keep some women in care, that the reasons that some of them weren't able to participate as highly as they did in the first year, oftentimes it was because the receipt of healthcare services just weren't as much of a priority for them. When they missed, they were wanting to go to job interviews and secure work and things like that. So what we were able to do to enhance participation in the groups was offer some sort of job enhancement. We did like typing skills if they came to the group visits, things like that to help enhance the value of that service to them. There were certainly some challenges to our delivery of this program on a very small scale. And what you all will be doing is delivering these services on a much larger scale, so a much bigger task in front of you all. And I think the challenges that face are related to many things. First of all, the discontinuity of healthcare on many levels has nothing to do with the good care you deliver. It's just how our health services are. Changing healthcare providers, having separate obstetrical providers and primary care providers, and sometimes those records don't get linked up. So one doesn't know what is happening in the other realm of that woman's health. Certainly women oftentimes don't know that what happened during their previous pregnancy is important to their health. They may not be giving that information to the primary care provider. So a lot of it is you have to be asking in a systematic way to obtain that information. And then, of course, a big barrier is that many women lose health insurance coverage 60 days postpartum, so they really didn't have access to care. And you have some special opportunities, I think, in your changing healthcare system that will address that one. And certainly, poor attendance of the postpartum visit. If that's not seen as a valuable visit, and we're seeing that as the kickoff of initiating this inter-pregnancy care, that's really a challenge. So somehow enhancing women's desire to participate in healthcare following birth is a huge issue. So what the really opportunities before you then are is to somehow in your position as primary care providers to help transform the idea of this postpartum visit into interconception care. Instead of the end of the pregnancy, it's sort of the beginning of a healthcare plan that helps address this woman's risk, her reproductive health risks and the risks that carry over from one pregnancy to the next. And I think this growing concept of medical home is certainly an opportunity where the idea of coordinating women's care and linking to community services, that this is just a right environment for doing this interpregnancy care project that you all will be implementing. So to take this up to scale, I think there's some really key tasks over the course of these learning sessions that you all will be thinking about. And the first one is knowing who your target population is in terms of who you really want to reach with inter-pregnancy care. I think Carla spelled out that, the ideal women to reach is every woman, right? Every woman, every time. It would be ideal to reach all women with targeted inter-pregnancy care. Sometimes, that if that's a little overwhelming to think about, sometimes we start with women who've had an adverse outcome. And the Louisiana waiver, for example, was really targeting these women with adverse outcomes, those who'd had a live-born low birth weight or preterm birth, a stillbirth, or an infant with an extended stay in the NICU. Again, those are those women who we know have a high risk of repeating. So having the providers aware that that is a starting point on the way towards doing this every woman, every time, that's one task. The next task is promoting women's attendance of the postpartum visit. And how can that be done? Not from a one-on-one situation of counseling, but from a systems approach. How can we employ a systems approach to get women to some sort of postpartum encounter, hopefully within 60 days of delivery? Sooner would be great. And to promote the ongoing attendance of primary care. This isn't, do their PAP, and then this is new guidelines. Women might not need a PAP for 3 years and see them back in 3 years, but maintain some ongoing continuity of care over the period of time. And then the key is to really deliver and coordinate that primary care that's occurring in this period that begins postpartum and extends forward across these 7 areas. And I'll just say them again, because these are the areas that primary care is being asked to focus on to provide interconception care. And they're all the things that you named when Carla asked you to call out. You all named these: reproductive planning and family planning, reproductive tract infections, nutrition, chronic disease management, substance abuse, psychosocial issues, depression, domestic violence, and periodontal disease as well. And then the final challenge, because no primary care practice can deliver all of these things, is knowing what your own resources are available under your roof, and then knowing what resources are available in your community, so someone in your practice could maybe assist in linking those women to those community-based resources that help achieve this plan. And I hope I'm on time. I'm sorry, we were speaking fast at the end, but we wanted to save at least 5 minutes now, I think, for questions about the model or anything else. And then there'll be lots of time throughout the day and throughout the subsequent sessions where we will delve into each one of these 7 areas in more depth to learn about how the screening may have been done or what the intervention really looked like. But right now, I think we should open it up to questions. So.
2 questions. One, did you look at the babies that were born to the moms? Did they receive any group care in the same way that the moms did for their health conditions, because many of them were born in the NICU and they have multiple complex health issues? And 2, when were they able to get family planning services on site at Grady when they went?
2 things. Yes, I'll start. Most of our moms, we enrolled women who had a very low birth weight baby. Some of those babies did die, and most of the babies were in the NICU for a good portion of the time that we were interfacing with them. So we conducted our group sessions within Grady Hospital. Upstairs was the NICU, downstairs was where we were meeting with them. If they wanted to bring their babies, they could, but then we followed them for 2 years out. The babies themselves were getting their health care in the Grady Developmental Clinic. So we weren't really linking our delivery. They were all under 1,500 grams, and they were all getting special pediatric care in our developmental clinic. So we were encouraging them to bring the babies. We tried to incorporate some breastfeeding and stuff into our sessions, but we were not really delivering care to the infants. Our resource mother was helping ensure that the babies got to their appointments when the babies did get discharged. So we were only engaged in helping coordinate the care for the babies. But oftentimes, these busy moms, we were very good about bringing their babies in. It's their own health care that was more of a challenge because, we do well taking care of everyone else. For the family planning, I'm very glad you asked that question. When we first began this, again, I was in Grady's system. I'm a family physician. They didn't want me doing IUDs or implants or anything like that. At first, they were requiring that I refer them all to the family planning clinic. And then we had so many women who kind of bonded with myself, the nurse practitioner, as their provider. We would refer them for the IUD because that was the method they were choosing, and then they would either not show up at the family planning appointment or they would go and say, I want my own doctor to do this. So just within 3 or 4 months into it, they then gave me privileges that I could do those things. And it went much better, I will say, for the women's, when we interviewed them afterwards about what was convenient. They like to get their family planning and their primary care from the same place. Just from a convenience factor, I think less transportation issues and problems for them, but also they had trust, I think, in their primary care provider to work with them to help them. I think Family Planning Title X is awesome, don't get me wrong. I think they do a great job offering a range of methods, but I think for these women who had so much going on in their lives, it was very convenient and to get it in one place. And I feel like they liked the conversation around, why spacing and so forth was important. Many of them said, now they probably were told at some point in their lives that spacing was important, but whatever, it didn't resonate with them. Most of them would say, that's the first time someone has told me that, family planning is important for that reason. And I'm sure it's because we had a lot of time in a group visit to cover this ground. It's not probably that Title X providers didn't do it, it just they didn't have the time to do it to the extent that we did. So another hand over here.
Yes. Your family planning birth spacing intervention in your program, is it client-centric or family-centric? And so, in essence, do you engage the partners at all in that component of the intervention? And I'm thinking of this based on an encounter I had with a patient that I saw recently, who I was seeing sort of as a consult for mid-pregnancy. And I was talking to her about birth spacing because this was clearly a short interval birth because I had seen the prior pregnancy. And she immediately looked at me and said, "You need to talk to him." Her partner was in the room and said, "We need to have a conversation with him." So it really is an area that I'm not sure that we're consistently looking at in terms of that overall planning. So was that part of your program?
Well, it's something we definitely learned as we went. When we started off with the women, we had, each of our group visits, we had a topical area of focus. And the first one we started off with was around planning and spacing. And so we had a whole, sort of session we delivered to the women. And we heard exactly what you said, is oftentimes they'd say, well, they were interested in some method of family. There were a lot of myths out there, a lot of fear around specific methods that we addressed, but also they would say, my husband or my boyfriend isn't interested in this. We tried then to have a few sessions where we invited the male partner in and we kind of repeated the session. We got feedback from the women that didn't go well. In a mixed group to have the men and the women, because some of them women were without partners. So then what we did was go to what your approach is then we would, after our group session, we would try to have a couple session with those who were interested. And we definitely saw that it was very important to get that information to the man to help the woman choose a method, but it was much harder to get the man on board with different methods. And it wasn't so much the fear of the method, but what we found was that often it was the man who wanted a baby right away. I'm not sure I'm using the right word, but for the sake of time, I'm just this almost replacement phenomenon. If the baby was in the NICU or the baby died, the man wanted another baby, and it was a much harder sell, I guess. He wasn't really. These men weren't hearing the idea about planning and spacing in the woman's health. It was hard, and I think what we tried to do then is when we had women who had identified an issue that contraceptive issues were a problem with their male partner, we tried to give two by two kind of care to them, but I'm not sure we ever completely broke through and were successful. I guess we recognize it as important, but we weren't sure that what we did really changed the man's. I think we were successful to some extent in that in comparison to the comparison group, we did better, but I'm not sure how much we improved, I guess, the communication for that couple. That wasn't something we measured, and it wasn't something we did consistently from the very beginning because we were learning as we went.
I think that it's a really important area because what I've seen, because I've been doing this a long time, and I've seen over the years that now as opposed to say 10, 15 years ago, for the moms that I serve or work with who are coming in for prenatal visits, there's a very high proportion of those encounters where their partners, their spouses, their significant others attend those visits with them. It didn't happen, in the past, and so I think there is if we as the community, as the healthcare provision community, focus on making sure we're engaging the male partner in a constructive way, I think there's a lot of opportunity because there's a difference in behavior now than was in the past.
And I think that would be a great way for, as you all move forward in doing inter-pregnancy care, to say you as practices want to adopt a couples-based way of doing it. And I think that would really build on what has been done before and carve out, you know, new lessons for all of us to learn from, because I think that's really important. Mhm.
Well, on the other side of that, though, is you see a lot of women that have 4 children at home and they come in to get their IUD because they're hiding birth control from their partner. So I think there's a balance that you have to find to
Mhm.
care for the woman still, but if there is a positive impact with the boy. Okay, that scared me. Sorry. So that's what I've seen often. So I think there's trying to find that balance of.
And I think that's why we said when we tried to bring everybody in the group session, couples, and that's why it didn't work, because it was more of an individual approach with a given couple. So we tried it once and said, whoa, we're not doing that again. We can do a group of all the women together, but not a group of the couples, because then it was just that extra dynamic. And then we just went for one-on-one with the couples.
Can I just add something here? I think this is a fantastic conversation, and I've already taken a whole bunch of notes in terms of work that I think we all could do. And I think what we're really talking about here is culture, like what's in the culture, having children, masculinity, being in a couple. Like there's a lot of issues that are very, very deep here. And, you know, maybe it's a couple's visit, maybe a couple's visit is dangerous. I too have had the experience of that being, you know, like very a bad outcome for the woman if you have that kind of discussion. It's very provocative sometimes. But maybe there's messaging that can be done in terms of birth spacing, you want a healthy baby, you know, healthy, like maybe there's other ways to get messaging out. That this group, I would really love to hear, you know, everybody's thoughts on it based on your personal experiences. So we're gonna kind of, you know, table this and keep it for future work, TA call, or another learning session.
I think there's a question right here.
I just want to know,
You guys are behind you.
ready?
Okay.
What was the average age in your group, and why was the group so small? Did you have difficulty recruiting, and why?
The average age of our women was right around 23 years, and I will say we did not, it was probably even that high because we did not include teenagers in our group. We had, again, this was 2004, 2005, we did not have IRB permission to include teen mothers in our group. So that was why we started with 18 up. Why we only had 29 women, I don't think we had difficulty recruiting because we recruited women right out of the delivery hospital as soon as they had an adverse outcome. I mean, it was pretty straightforward, 1,500 gram baby. We went in and with our resource mother and we recruited and enrolled and they were getting I think incentive for them was primary care for 24 months, women who would otherwise lose it. The reason it was so small is because with the funding that we had, they said you have 3 months essentially to recruit all the women you can get in 3 months, and then cap off recruitment, then we're funding you to follow whoever you get in 3 months for 24 months forward. So who did we miss? In that time that we enrolled the 29 women, there were 36 women who were eligible. So we still missed some, but we got 29 out of 36. And again, there were more than that in terms of very low birth weight. They had to meet our eligibility criteria, 18 and over, African American, and we wanted women who resided in that catchment area of Grady. Some women get transferred to Grady because they're very complicated obstetrical issues going on, and they go back. We didn't want the transfer women. We wanted women who lived there so we could follow them for 24 months.
I think we
Well,
have,
great.
yeah, maybe 1 or 2 questions. and then
She's
we
been
need to
wanting
keep
to ask a
going.
question in the
Where
front.
are we?
Right up front, I can't see your name.
Coming.
Rachel?
Okay. My question, you said that you had several women who had substance abuse. Did you look at your data to if there was a way to decipher if those women had babies that lived versus expired?
You know, we never went, we didn't go back and do that because we didn't have permission again from our IRB standpoint to follow the infants at all, because on an ongoing way. Because once the woman either left the study or withdrew from the study, we could no longer continue to follow the infants. And again, most of these women, it was through the resource mother. They either had like positive urine drug tests, or in the initial screen with the resource mother, they were admitted that they had cocaine problems, or that was the most common drug that we were dealing with, or they had issues going on legally that were going on, And we didn't want to exclude them. And looking back, we were getting a lot of advice at the time when we were doing this. People said, don't even try, just exclude any active substance abusers. But again, wanting to take a very general primary care approach, we thought we're going to invite everyone who fits. And looking back, I guess their concern was to make this study look bad, but I thought it was important to learn, to see, can you engage them with this? I didn't think necessarily our care would engagement, but our resource mother was pretty awesome in what she was providing to them, and very motherly, very but authoritative at the same time, and going out into the community. And I guess the big lesson was just it takes more than that when there's substance abuse. So I don't know what it takes, but I know it takes more than what we did.
Yes, my question is, and I am familiar with your model and viewed the earlier work. And my question is that what is going on now? After this study has been done and it has been, the effectiveness of it has been demonstrated, are you continuing to do the work? Is it being replicated? Because again, your cohort was still a fairly small number. And so I would like to see what the future outcomes and what has happened since the time that that this group ended, and what's happening right now.
Okay. When we first closed into sort of enrolling new women formally into what was our study, I was still a primary care physician at Grady, and my nurse, my partner in crime here, the nurse midwife, we were both primary care providers and nurse midwife at Grady. So we were just, what we did was we continued to provide primary care, and those women with adverse outcomes were referred to us for their primary care. We couldn't follow anyone. We weren't trying to make it really like a study per se. We were just trying to make it the routine care. And we did that for about 2 years. We never had the extent of participation in their own health care that we got with our Grady model, because what we were missing during and all that was the resource mother. We had a nurse case manager who would still call and try to help women meet their appointments, but we didn't have that resource mother going out into the community or helping with transportation. So, I think that without some partnership with a home visitation model, it's hard to even get that level of participation we had when we had that funding in a study. We still got them coming for their care. We didn't follow outcomes because we weren't trying to put them in a study, but we've still got good referrals from the OBs and a lot from the pediatricians in the developmental clinics, and there was a very low birth weight baby. Now what happened, now this is again more of a systems approach. I'm not sure that we really had a system. What we had was really passionate people, and then for political reasons and other, Emory no longer wanted primary care at Grady. So Grady still has primary care, but you can't be an Emory faculty and be a Grady doctor, so in primary care. So I was no longer able to work at Grady, and neither was the midwife and so forth. So then what we did was an electronic medical record approach. We tried to build the prompts and the screening into our EPIC medical record. That's going on. I'm not sure that there's really targeted referral of these very low birth weight women now. So that's kind of the Grady situation. But then what we worked on, this may be a bigger question, is Georgia has an 1115 waiver, much like the Louisiana waiver, but we specifically went to Medicaid and said, what we want to do, we can see trying to work on this in one healthcare system with no real support and buy-in isn't sustainable, right? So what we wanted was a policy solution. So we worked with Georgia Medicaid to request an 1115 waiver for Georgia, which is a Medicaid extension, which would say all women, not women at Grady, but all women in Georgia who have a very low birth weight baby, the same criteria we had for our study, except it was limited to race, ethnicity, all women with a very low birth weight baby below 200% of the poverty level should receive Medicaid coverage for primary care for 2 years. That CMS bought into that, so we were awarded a waiver for the state of Georgia January 1st, 2011. We are now we're into our final year. Basically, we're enrolling through June of 2014. So women who deliver babies in Georgia under, right from the start, Medicaid, then get enrolled into their interpregnancy care coverage for 24 months. And I still really don't expect to see the outcomes and participation from the grading model. We do have resource mothers who are involved from the level of the care management organization, the Medicaid care management organization, but it's all telephonic case management. It's not home visitations. So really, we're just getting the data coming together. We're waiting for a big data download from Georgia Medicaid as we speak, and we're going to be kind of looking at those numbers to see, did this sort of coverage model make a difference or not? So kind of two things, two answers to your question.
So we are going to get